Hello everyone. This is a presentation about the approach to a patient with headache from Group 8. Headache is one of the most common symptoms in clinical practice and may be classified as either primary or secondary. Therefore, it is important to note the cause of the headache and how it should be addressed. At the end of this presentation, the viewers will be able to know the case and its pertinent data, the diagnosis, its definition, etiology, epidemiology, pathogenesis, clinical manifestations, diagnostic criteria, management, and lastly, the case resolution. This is the case of patient X, 27-year-old female, who saw consult due to left-sided suboccipital headache. For the history of present illness, the patient stated that the headaches began insidiously in childhood. Approximately 8 years prior to this physical therapy consultation, the headaches increased in intensity and frequency to such a degree that she sought treatment. Symptoms with that episode partially resolved with osteopathic manipulation, but were never completely eliminated. At that time, her job involved frequent lifting. Symptoms had become more intense and more frequent over the past 6 months. She complained of an aching pressure on the back of her neck at the base of the skull. The pain, ranging from 5 to 8 out of 10, extended into the occipital region. Her neck felt though as though there was a pop, with movement and fatigue after about 2 hours of computer use or paperwork at her desk. The headache was continuously present and increases in intensity throughout the day. She did not experience any associated signs and symptoms listed. However, she was an office clerk, which required her to work with a computer most of the day. However, about 1 to 2 hours, 3 times per week, she was spent lifting 11-kilogram file boxes from the floor to wayside. The most intense headache would come on about 3 times per week and would last 2 to 6 hours, which she attributed to lifting boxes on those days. Interventions for this episode include 2 treatments of osteopathic manipulation, which did not change the symptoms. Medication included a pain reliever, which contained acetaminophen, aspirin, and caffeine. She would take medication only when the headaches were at their worst, and this helped to decrease the pain intensity. Her goals were to decrease the frequency of the intense headaches and to be able to tolerate the computer work, desk work, and lifting without increased pain. The patient was referred for physical therapy by her family physician. With the presented pertinent data, a physical examination focused on the cervical spine was done to further localize the source of the disorder. Patient X showed flattened cervical lordosis and thoracic kyphosis. There was light forward rounded shoulders and moderate forward head held with chin extended forward into a moderately excessive upper cervical extension. This could have been caused to the closure of the upper cervical facets contributing to her symptomatic state. Significant limitation was found in upper cervical flexor muscle performance. For strength, endurance, or control of these deep neck flexors could have contributed to the patient's neck pain and headache during sustained postures and lifting. The weaknesses in this patient's middle and lower trapezius could contribute to her limited endurance and tolerance for sustained postures and lifting because of the extra strain. There is also tenderness of the upper cervical extensor muscles, and they may have related to the patient's postural deviation. Lastly, PPIVM testing revealed hypomobility and reproduction of patient excess headache symptoms, which could indicate articular involvement. The findings and medical history support the diagnosis of cervicogenic headache. So what is cervicogenic headache? It is a headache that is caused by disorder of the cervical spine and its components, bony disc, and/or soft tissue elements, usually but not invariably accompanied by neck pain. For CGH, the mean age of patients is 43 years old. This occurs mainly in females, and the mean duration of symptoms is 7 years. Onset of pain is from the neck or occipital region. The risk factors that can be attributed to CGH include trauma, occupational hazards due to poor ergonomics, female gender, inappropriate posture, or strenuous activities. Cervicogenic headache may be a result of articular dysfunction or cervical degenerative disease such as osteoarthritis of the facet joint, or possibly muscle dysfunction, which is poor or limited cervical strength, muscle fatigability, decreased flexibility, or weaknesses in the stapling muscles, or also due to nerve involvement with compression, infection or inflammation, or complete blockage. This list shows the specific possible sources that can cause cervicogenic headache, which relates to the etiology and pathogenesis. Now, for the pathogenesis specifically, this involves the convergence of the cervical and trigeminal afferents in the trigeminal cervical nucleus. This table represents a list of CGH pain generators, which also includes specific innervation and the type of referral pain. Clinical manifestations of CGH include symptomatic headache with unilateral symmetry that may be bilateral only when the pain intensity is severe. There can also be moderate to severe pain intensity, non-throbbing, non-lacinating characteristics, a pain that starts in the neck and radiates forward in a C-shaped pattern, or in episodic or continuous timing/duration with fluctuating severity. CGH also has associated signs and symptoms which are known to include attack-related phenomena. These include autonomic signs and symptoms such as lacrimation, nasal congestion. There are also typical migraine symptoms. These are nausea, vomiting, phonophobia, but they are present in CGH, but in a lesser frequency and lesser degree. There may also be seen ipsilateral edema in the periorbital region, ipsilateral blurred vision, dizziness, and discomfort in the throat or swallowing difficulties. According to Harrison, CGH may also present like the symptoms of migraine because they have the same triggers. For the clinical manifestations, there are cervical features that include the pain that involves the neck with radiation to the posterior and the anterior regions of the head, movement of the neck or sustained head posture that precipitates head pain, external pressure on the occiput or subocciput or upper neck may precipitate head pain. There's also restricted range of motion of the neck, and additional features include ipsilateral shoulder and arm pain. In a clinical setting, the manifestations presented by the patient with history of PE are usually used for the diagnosis. Here we have an image on the right which shows a complete checklist of CGH manifestations according to Biondi. The International Headache Society has established a diagnostic criteria for CGH. Any headache, which includes any headache fulfilling Criterion C, clinical laboratory, or imaging evidence of a disorder or lesion within the cervical spine or soft tissues of the neck known to be able to cause the headache. Evidence of causation demonstrated by at least two of the following. A headache has developed in the temporal relation to the onset of the cervical disorder or appearance of the lesion. The headache has significantly improved or resolved in parallel with improvement in or resolution of the cervical disorder or lesion, or a cervical range of motion is reduced and headache is made significantly worse by provocative maneuvers. And lastly, manifestation should not be accounted for by another international classification of headache disease. Imaging can provide evidence for diagnosis, but abnormalities of the cervical spine alone, without appropriate symptoms, physical exam findings, and responses to appropriate nerve blocks cannot be diagnostic for cervicogenic headache. Nerve blockade, done for diagnostic purposes, may involve the greater and lesser occipital nerves, the cervical segmental nerves, and cervical facet joints. Meanwhile, another checklist shown is the major criteria encouraged by the Cervicogenic Head International Study Group. In this figure, a summary of the diagnostic approach specific to the patient according to her clinical cues. Also, it shows how the impression of the case has narrowed down to CGH, with migraine and VAD as the differential diagnosis. As we talk about the differential diagnosis of CGH, this includes of migraine type, tension type, or menstrual type. This can also be due to temporomandibular joint issues, vertebral artery desiccation, or due to lower cervical dysfunction. Combined approaches are usually done to treat CGH. Use of medications alone are often ineffective or provide only modest benefits. Thus, it should be combined with physical therapy, anesthesia, and occasionally surgical intervention. It's important to note that developing an individualized treatment plan enhances successful outcomes. Pharmacologic treatment, which are proven effective but not approved by the FDA, includes tricyclic antidepressants and anti-epileptic drugs. These also include NSAIDs and muscle relaxants. There are also non-pharmacological methods to manage CTH. These include osteopathic manipulation, physical therapy, and individual psychotherapy. Interventional methods includes anesthetic blockade, neurolytic procedures, botulinum toxin injections, which are not FDA approved, and the occipital nerve stimulator. Surgical interventions are also done occasionally combined with other therapeutic methods. These include neurotomy, dorsal microvascular decompression, nerve exploration release, or joint fusion. So when we go back to the patient, this table shows the detailed summary of the treatment of the patients. This includes manual therapy for reducing the frequency, duration, and intensity of the headaches, and muscle re-education exercises, so she can have improved ability to hold static postures and to control her functional movements. Now, the patient undergone successful patient education, exercise, and manual therapy techniques to address impairments and functional limitations over the course of 8 clinical visits in a duration of 8 weeks. Our patient has attained full strength in the muscle group that were limited and gained pain-free cervical range of motion. Her goal was met as she had decreased headache intensity, frequency, and increased tolerance for functional and work activities. We can see in our patient that the goals have been achieved. Thank you for your time.